Welcome to episode 148 of the Urology Coding and Reimbursement podcast. I am your host, Scott Painter, with my co-host, Mark Painter and Dr. Ray Painter. And we want to welcome back special guest, Dr. John Lin. Dr. Lin is a solo practitioner in Gilbert, Arizona, in the Phoenix area. He's a moderator of the Thriving Urology Practice Facebook group. And I'll let John explain a little bit more about that group and how to join. John, welcome. Thank you for joining us today.
I can't wait to share some more awesome information with your listening audience. The Thriving Urology Practice Facebook group is actually free, and as Scott would say, if it's free, it's for me. It's a forum where a bunch of U.S.-based urology practice folks get together and we crowdsource practice management solutions for everyone's benefit. And those vendors who are listening, I know some of you are listening, do not bother joining because it is a safe space. I want it to be a safe space for urology practicing people to freely discuss what we think of a certain product or service. And we also discuss coding, billing questions, and the questions today came from this wonderful forum/group.
Yes, and today I'm going to let John take it over and share with you what the questions are. You know, we did answer a question last week that came from the group as well. But I'll let John take it over and share with you what we're going to talk about today. And it's all yours, John.
All right. We have a few questions to cover this week. And I can't wait for Mark to tackle some of these because a couple more are good ones. So the first question states, what codes should we be using for MRI fusion biopsy of the prostate? Is it all of the transrectal ultrasound biopsy codes, such as 76872, 76942, 55700, 64450, A4512, with no additional codes? And to unpack that, let's go over to 76872. It is transrectal ultrasound. 76942 is transrectal ultrasound. And 76872, also transrectal ultrasound.
Yeah, so when you're looking at those short descriptions, right, the 76872 is the diagnostic, and the 76942 is the
ultrasound guidance.
Yeah.
And then you have 64450, which is injection of anesthetic agents and or steroid, other peripheral nerve or branch. And 55700 is the actual prostate biopsy code, and A4512 is a needle code. Mark, what do you think?
So I think first of all that that was some old data, unfortunately. So the first thing we probably should address is the right set of codes to use right now. So the A4512, actually, I can't even find that existing anymore. So that one's not in the current code set. So that one we should remove. And I hate to do the redaction before we actually talk about the extra work involved in the MRI fusion biopsy, but it is the way it is, right? So, and unfortunately, Medicare, and with reluctant support from the AUA, has basically looked at the 76872 and the 76942 as mutually exclusive. So those two codes, if you were to bill both of them together, the lesser paying code, the 76942, is the code that would typically be paid. And I want to just double check that to make sure I'm staying current.
Yeah,
So
76872 is 0.69 RVU, while 76942 is 0.67 RVU.
yeah, and actually, I'm sorry, those are not mutually exclusive. They're just included codes. Um, so, but what we've seen a lot of the payers do is actually flip pay and pay the 76942 versus the 76872 when those are billed together. So the appropriate coding right now for a standard, we'll start with that, a standard uh, transrectal ultrasound guided biopsy is the 76872 if that documentation supports that the diagnostic process was accomplished. So you got a full picture of the prostate. You're describing the overall prostate size and its general anatomy that you see on the ultrasound. And then go ahead and do the guided biopsy. That would be a 76872. If the documentation simply supports that all you did was use the ultrasound to guide the needle to the appropriate site, then the 76942 would be appropriate. So those are either ors now with just about every payer. Now there's a couple of payers that will still honor the 3 codes. So you can find out in the private sector side by testing those. But if you're talking Medicare and Medicare Advantage, you should be using one of the other ultrasound codes plus the biopsy code. Now I kind of glossed over the last code, which is the anesthesia code, the 7644 or 64450. So that's actually a code that typically is A, not performed, and B, bundled. That is an injection into a specific nerve. And ultimately, most people are doing a general anesthetic injection around the prostate and not actually pinning down the appropriate nerve to use the 64450. And then you still have, even if you are actually injecting the correct nerve to actually meet the definition of that code, that still gets bundled in by the majority of payers and is actually thought as not appropriate coding. So either of the ultrasound codes and the biopsy code are the standard TRUS or the TRUS biopsy, the transrectal ultrasound guided biopsy.
Go ahead.
I was just gonna say, and this continues to be frustrating because you're doing a lot. It seems like you're doing more work, but the pay just isn't. You can't find that the pay looks like it should be higher, and that's why I think this question comes up a lot.
Agreed for the standard, and it's even worse for the MRI fusion biopsy.
Right.
There is a code out there, which is an interesting code. And I'm by trying to remember all these things off the top of my head. It's a 6-7 code.
Well, let me just do a quick summary. Sounds like, Mark, what you're saying is 55700 and 76872 or 55700 and 76942 in 2023 when you're coding for a prostate biopsy, transrectal ultrasound guided biopsy. Depending on your documentation and what is done, actually documented, you would choose one or the other transrectal ultrasound codes. And if you're going to bill for the 76872 for the measly increase of 0.02 RVUs, you better document and capture the images to satisfy the requirements for a 76872, a transrectal ultrasound of the prostate.
That is correct.
And unfortunately, all that extra work of an MRI fusion is uncompensated. That's what I'm hearing.
So now let's move to the MRI fusion. Yes. So there have been multiple discussions around what we need to do with the extra work that's required. there's an MRI that's done, obviously. Now, typically that MRI is done at another facility, and there's a read professionally done, so that that MRI is not typically one that is chargeable by the urologist, because someone else has already been paid for that. And that's typically your 77021 as your, no, that's the 7. I'm getting that one all confused with that's an MRI guidance code. The 72095, does that sound right? It's the abdominal and pelvic, or the pelvic MRI. So if somebody could look that one up for me. But the MRI is separately paid for typically. Now, if that was done by your facility, then that would be something that at least the group got in that regard. And then, of course, there are accreditation rules with actually performing an MRI that you need to make sure that are met there. So the MRI is already paid for. Now the MRI comes over, it's run through the machine and merged with the ultrasound to help you do the guidance in a little more precise way. And ultimately, that process, there is a code that is 76376, and let me read you that one. This is 3D rendering with interpretation and reporting of CT, MRI, ultrasound, or other tomographic modality with image processing under concurrent supervision, not requiring image post-processing on an independent workstation, which actually does a pretty good job of describing kind of what is being done during that MRI. And so that is a code that does have a payment assigned to it, not much, $22.40 nationally, because it's pretty much done by the computer. But it is a code that is bundled into a lot of your radiologic services. And luckily, the 76872 or the 76942 are not part of that bundle. So that may be an option for you to get a little bit extra for that, but it is a code that has had some issues with coverage in the process. And you do want to make sure that you're clearly notating in your documentation that that is being done for that processing. So that's one extra code we can look at, but again, not much of a bump, but a little bit for what you're doing. So if you're looking at a standard MRI fusion transrectal biopsy, that 55700, along with the 76872 if the diagnostic is included, or the 76942 if it's simply directed, and then the 76376 look like the correct code set. No codes are allowed for the anesthesia for that prostate block, because it's not really a block. It's not really anesthesia, and anesthesia by the surgeon anyway it's governed by a bunch of rules. So we'd have to steer clear of that. Now, the other thing I've heard is that some folks are actually doing transperineal biopsies when using MRI fusion or some of the newer technology like an MRI guided fusion. And if you are doing transperineal, then one of the codes that we considered in some areas is the 55706. Now, the 55700 does state any approach for a biopsy, and it does include biopsies versus just a biopsy. Now the 55706 is a transperineal saturation biopsy. And so that one, when you look at that, the argument that's gone back and forth, and I've been discussing this with a few different groups, is what is a saturation biopsy? Do you have to saturate the entire prostate? That's not in the description. I think if we dug under the covers, that the value was probably based on a total prostate. But the way the description reads with saturation biopsy, the question is if you saturate a specific area of the prostate, could the 55706 be an appropriate code for that service? You'd still have your issues with your ultrasound guidance and everything, and we'd have to, Scott, is the 55706 one that includes the image guidance?
Yes, it is.
So that one, if you're looking at that 55706, then it's probably not appropriate to bill the 76872 because that's image guidance. But you might be able to still look at the 76376 for the processing because that's above and beyond. But those are all areas that we're all struggling with because there is not a great opening here. And then, of course, the other option you've got still out there, if you're doing transrectal, and ultimately, if you're even doing transperineal and don't feel you're doing a saturation biopsy in that regard, then the 55700 with a 22 modifier for the extra work of dealing with the image guidance that is enhanced now with the MRI. And if I'm going to go from my strict compliance perspective, the 55700 with a 22 modifier, either of your ultrasound codes, depending on the documentation, and the 76376 would be the combination of codes I would say is most appropriate coding wise. And again, the other side, if it's transperineal and there is documentation that does say it's a saturation of a portion of the prostate, I'm going to leave that door open, but not put that into the ultra conservative side of coding.
Sounds like you're saying that MRI fusion biopsy should be 55700 modifier 22 and 76872
for if as long as the diagnostic is medically necessary and well documented.
Got it.
Yep.
And we'll hold the door open for the MRI guidance code.
And hope that the AUA and the AMA are starting to work on new codes.
But that means everything is going to be re-rucked.
Exactly.
Which all the other codes, existing codes, are going to be devalued.
It is. We'll probably have a high end and a low end, and a lot of things are going to end up on the low end, and so it's gonna be interesting to do. But I think there's been enough hue and cry around this that they're going to have a hard time holding off much longer. I'm not going to say it's imminent, but sooner or later, I think this is going to have to get redone.
And Mark, if you could just explain re-rucking for anybody that doesn't know what re-rucking is. We use that and throw the term out a lot, but some people may not know what re-rucking actually is.
So anytime, and for a perfect and very recent example, we got a new code this year, the 55867, for the laparoscopic limited prostatectomy. And when that new code came in, it requires all of the codes in the same family to be put up against through the relative value update committee. And the relative value update committee, that's where RUC comes from, RUC. When they go through and they look at new data, relative to the older data that most code values are based on. Everything tends to be shifted downward. Operative times, recovery times, all those things, from an objective standpoint, have probably decreased over time since the beginning of the performance of those procedures as people have gotten better. But the other side of the coin, of course, is how are those surveys answered? And, typically we don't have a high response when the AUA asks for relative value support. So number one, I would encourage you to actually respond if you get asked to do a relative value survey, if you perform that procedure. And number two, make sure your operative times are really based on your average, not your, if everybody gives their best case, then that actually hurts the relative value going forward because the intraoperative time goes down. And then, of course, recovery times and those types of things built in, when those get reanalyzed with shorter hospital stays, those take values out. So when anything gets revalued, it always ends up going down. Some of it politics, some of it the reality of where we are. But in the end, Medicare is not going to add more money just because a new procedure comes in. You're cutting up the pie with one more slice. And as you do that, you tend to lower the values of everything in the same family.
A lot of people don't realize that. We just think, why can't I have a new code? Well, with that new code, you're going to take a haircut with all the other codes within the same family. And that's what re-rucking does. And I will
Re-rucking's a bad word.
Yeah, 4-letter word. And I'll re-emphasize what Mark said. Whenever the urologist received a survey request, usually it's via email, you want to make sure you answer that honestly. First of all, you want to answer it if you perform the procedure. And number two, answer it honestly. And you don't want to be the hero. You don't want to say, well, I can do this in 5 minutes. You want to look at the average time it takes for the typical urologist, for you to do the procedure, and not when you have that best day when the planes are perfect and the nursing support is perfect. You want to use the average case and not the best case when you answer these questions.
Ray, your take?
First, I'll echo what John said. Urology came out very well when we first got compared to other specialties when they first went to the relative values. And that's because Mark and I helped the AUA educate folks as to how to answer these questions. And as it went through the process with the feds in the very beginning, we helped the AUA and urologists establish a good practice management base. And so every time things get re-rucked, we lose. So that your answer is totally correct. And I have 3 questions for Mark on the fusion biopsy and MRI biopsy. Number one, the perineal fusion biopsy used to include verbiage that says you got to have a grid, and they wanted to be sure you were systematically biopsying the prostate. Now, I'm not against it being a specific part of the prostate, but I think that's still there. So you don't want to just do multiple biopsies and call it a fusion a perineal fusion biopsy, correct?
So that is a very good point. It is template guided. And my understanding from talking to these folks is they are using a template within the machine to develop where they're going after those biopsies. So I left that out, and so I'm glad you asked that question. That they're
and that should be well documented if you're going to charge that code.
Correct. The saturation, the template guidance, and then of course it does include the imaging. So
and I want to make sure the audience understands that we are talking about 55706, And I'll read the description. Biopsies, prostate, needle, transperineal, stereotactic template-guided saturation sampling, including imaging guidance. So if you're going to charge 55706, you don't get to charge the other transrectal ultrasound codes because 55706 includes imaging guidance. And what you're saying, Mark, is that the template guided saturation, it could be template via grid, physical grid on some sort of amount, or the template as a template from the MRI fusion system.
Correct.
I agree with that. Even though I know when the code was developed, there was no MRI template. So the spirit of the code is probably that physical rectangular thing, that grid that is mounted on a guide.
Without a doubt, if you take the history there, it's tough to put this in place, and it took me a while to get there. But again, with so much of what we deal with today, we deal with what is the description, and what does the description say, and how do we interpret that description based on where we are today. And so that's why I'm not saying I'm wholeheartedly endorsing this, but I've come around to at least understanding why this is a possibility, given the actual technology and how it's performed.
What I'm hearing is that the more you know about how these codes are developed and the background from which these codes are developed, the more difficult it is to answer this is the code or that's the code, because technology changes.
This is where I'll give the AUA a bit of a pass on all of this. So the AUA, right, works with CMS. And when they do RUC surveys, they have to put a coding vignette in there. And so anytime the AUA is asked a question, they have to, in playing the game with CMS, basically understand where the relative values came from. So they're cuffed even further in knowing the development of the code and the vignette that was assigned to that as to how they can answer things. So if you ask the AUA directly about using this 55706, they would have to say no. It probably doesn't fit the vignette. So because that vignette was developed when the code started, and they didn't have this technology. So it is one of those areas where we're arguing based on the actual definition of the code and applying it to today's technology. So it's one of those things that it's not good to be static in everything, but at the same time, you have to know what you're up against and where the payers are probably going to go.
The more you, and I've just mentioned this in a recent video that I did about urodynamics coding, the more you know, the more difficult it is to answer a coding question with a straight yes or no.
Yes.
Should we go on to the second question?
I have two other questions.
Oh, go ahead. Go ahead, Ray.
Mark, on the imaging associated with the saturation biopsy, you definitely couldn't charge the imaging for the needle guidance, but is there any wiggle room to charge for a prostate ultrasound prior to the guidance into the same procedure?
All right, so you're sticking with if I did a pure diagnostic, I had to finish up how I was going to do my saturation biopsy.
Right.
So if that documentation supported the pure diagnostic piece, it's X-rays and imaging is not part of the general bundle. So I would say yes.
And we would add the caveat if it was medically necessary to do that.
That's correct. And it's a good way to put it. As you're going through that. I mean, it is purely diagnostic and it does need to be done.
Yeah.
Then, yes, a 76872 should probably be okay. 769 would never.
You mentioned that the procedure of the computerized fusion had a code that some pay for and some don't. Does Medicare pay for that?
So I'm early on in seeing people try that code. So I can't really give you a good answer to that particular issue.
Well, I don't know what they do right now, but they used to not pay for any computerized function. Like
So it is valued and it is a status A code. So you know, it's not necessarily bundled. So again, we're watching what the rules are and how they changed. It did used to be a bundled code. But I think with the advent of some of what they've been doing with mammograms and fusion mammogram reads, that they've opened that up a little bit.
Ray, were you asking if someone billed a 55706, can someone also bill 76872 concurrently?
I'm not doing, I don't do numbers, John, so I don't know.
55706 is the
The fusion code that Mark said paid $22. That code is a computerized function
correct.
that Medicare used to not pay for, and Mark is saying now that they've opened that gate, so you have to try it.
That will be 76376. Got it.
But you did ask first about the 76872, which is the diagnostic ultrasound, and it's not bundled.
No, the 55706 and the 76872 are not bundled, and that's what you were asking. Could you bill those two together? And the answer was, if medically necessary and documented appropriately and done for the diagnostic purposes.
And also 76872, the transrectal ultrasound with 76376, the MRI imaging, you can, according to the AUA Coding Today's bundling matrix, you can build those two together.
That was the reason for the question.
Yeah, that's what I figured.
All right.
All right. I think we explored that one thoroughly. That question.
I hope nobody's confused.
I'll try to distill that. Should we go on to the second question? This will be a nice, fun, and quick and easy one.
Yes.
All right. Second question from the Thriving Urology Practice Facebook group. Medicare denied a claim stating patient died on March 2nd of 2023. Well, the actual date of death was March 23rd of 2023. So this was obviously a data entry error. Any ideas on how to correct this? My biller says Medicare only accepts edits from the patients, but that is unlikely to happen in this case. And if it does, and the claim gets paid, getting paid the claim is least of her worries. So how do you correct a wrong date of birth with Medicare?
Date of death.
And Mark, I want to know the question. My real question is, what is the ICD-10 code for miraculous resurrection of this patient?
I have not yet seen that ICD code for resurrection. So there's not a good way to push that one through. And unfortunately, probably even with the right resurrection ICD-10 code, Medicare is going to want to see something, somebody to find out that they actually didn't die on 3/2. So the only thing I could really think of is see if you could get a copy of the certificate of death, and have the patient's family submit that to Medicare. And that might be something that they would be willing to do. Imagine that your bills are not the only ones coming in, probably for this particular patient. So it would be in the best interest of the family to do that. And as difficult as a time as they're probably going through, that's probably the path I would take, to have the family produce a death certificate to get that corrected.
Sounds reasonable.
Yep.
Hey, I know we're running short on time. I was wondering, the first question went a little bit longer than I thought it was going to take. Should we table question 3 until next week, or should we plow through?
Probably table it for this episode. Yeah.
Very good. So I will table the TURBT and stent placement question until next week.
Sounds good. Okay, let's wrap this episode up here. Let's go around the horn for some final thoughts, and we'll start with our guest, John. Final thoughts.
All right. If you think this is not fun enough and you have more questions about coding and billing, I would like to highly encourage everyone to consider attending the Urology Advanced Coding and Reimbursement Seminar. This year, it will be held in Las Vegas in December and New Orleans in January of 2024, where we can go deep dive. We'll deep dive into these and other various topics to help improve your practice efficiency and maximize your revenue ethically and legally and compliantly.
Yes, and you can go to prsnetwork.com/148 for a link to register and a special code for our podcast listeners for a discount. So do encourage you to get signed up and get registered. It's a great time. All right, Mark, final thoughts.
So I guess mine is a little broader in all of this, and that, the coding issue of dealing with our advances in medical technology has always been, for me, a fun thing to look at. I mean, and right now in urology, after a period of time where we didn't see a lot of innovation, there is a ton of stuff coming down the pipeline for urology. You know, in the last few years, we've added different ways to treat BPH, some prostate cancer treatments. There's new stone stuff. I mean, there's just all sorts of things that are out there right now. And, you know, I think every urologist's first question for any new technology is, does it work? Is this going to improve patient care? And that's where it should be. But that second piece is where I enjoy having a little bit of fun, is trying to figure out how to navigate the reimbursement side of this. And it is not easy, given what we talked about today with the rucking process and the general nature of CPT. We've got more and more codes going the category 3 route because of some of the issues with the standard category 1 codes. Those are the codes that you have to stay awake till the end of the CPT book to get to. There are codes that end with a T. So we've got those codes that we're seeing some significant growth relative to urology. And then we've got unlisted codes and modifier 22s and 52s. So there's a lot of things that are out there that are either in the market or soon to be in the market, that we're exploring the best ways to navigate the reimbursement side. And then, of course, you got that secondary issues of coverage. So that one's out there as well. And so all of those come together in a very convoluted way, but they are going to be a focus of some of the things that we talk about at the UACRS. And actually, hopefully, Scott was working on maybe trying to get some of the the folks that have this new technology to join us to talk about the clinical piece as well. And so we can come up and behind them and look at the reimbursement side. So it's an exciting thing. And it does keep me alive and questioning everything that we're doing as we go through this process. So although it's difficult, and I know on the back end it's not as much fun for me or for you guys as it is for me trying to navigate this up and think about all this stuff. But it's important to understand those possibilities and where they are and how to talk to your payers. But it's also important, and we did skip past this a little bit, but to understand what your payers require before you do the procedure and what the opportunities are on the back end before jumping whole hog into this stuff. So make some calls. Don't be afraid to check around. Don't be afraid to knock heads in the PRS forum or the Thriving Urology Practice. I mean, it's going to take a village for all of this.
Ray, thoughts?
Well, this discussion today just shows that little things mean a lot. There's a lot of details and you got to do a lot to keep up. And we've used our experience to come up with a way to keep all of you totally engaged and up to date. We've started a fellowship in urology for urologists that if you stick with us, you will know how to document and know how to communicate to your coders and to pull in exactly payment for what you've done. And for coders, we're going to certify you as to the next level of coding and keep you up to date with continuing education. We're excited. It's taken us 30 years to learn how to do this, but we now know what we're doing. And we'd like to have you join us.
Awesome. And you can find more information. I'll put that in the, make sure that gets into the episode page as well. Once again, that's prsnetwork.com/148. Also, we'd like to thank ModMed for sponsoring this episode and encourage you to check out their practice management and EHR solutions. Go to modmed.com/PRS Network for a special offer for our podcast listeners. All right. Thank you all for the great episode. Take us out, John.
Happy coding, everyone.